Dear students, today we will deal with cornea. Cornea is an important refractive surface. It has 40 diopters of refracting power, plus 40. It converges 40 diopters of parallel incoming light and presents it to the lens. Lens converges the same rays, another 18 diopters, and thus we get an image formed on our retina. So these are the two powerful refracting surfaces, and the eye as a whole has a refracting power, a dioptric power of 58 to 60 diopters. So cornea is very important for vision. Even corneal edema will compromise vision so much because the corneal clarity is lost and cornea's ability to converge light is lost. Even a small opacity, a very nebulous opacity on the surface of the cornea will cause very much obstruction of vision. So cornea is such an important structure, and understanding cornea becomes very important for any student of ophthalmology. Anatomy of the cornea is almost something which I'm sure you'll all be very familiar. It has five layers. The epithelium is the first layer, Bowman's is the second layer, stroma is the third layer, decimus is the fourth layer, and endothelium is the fifth layer. The pre-decimus layer of Duva is a recent addition to the number of layers. So you can even argue that cornea has 6 layers, but conventionally we usually say cornea has 5 layers. Traditional wisdom is 5 layers. In fact, the Duva's layer was a recent discovery by Harminder Dua, an Indian-born ophthalmologist who found out this pre-decimus layer of Dua. So taking it aside, we usually consider cornea to have 5 layers, of which epithelium regenerates well. In fact, epithelium is the only structure which regenerates. Remember that. Next is the Bowman's membrane. The Bowman's membrane is a very precious layer. Any injury or any insult to the cornea that goes deeper to the Bowman's membrane will never heal totally. It will always have a telltale evidence, which we call it as a opacity. So any injury that breaches the Bowman's membrane will usually heal with an opacity. Remember that. And very close to the Bowman's membrane, sub-Bowman's membrane, there is a very rich plexus of nerve, and the nerve is from the nasociliary nerve. The nerve fibers which are present in the sub-Bowman's plexus is mainly from the nasociliary nerve, which is a branch of the ophthalmic division of the trigeminal nerve. So cornea, by this nasociliary nerve, is very sensitive. You just need to have a foreign body in your eye which will never allow you to sleep. Somebody has to remove it. If a foreign body falls in your eye, you can never bear it and tolerate it and just keep quiet. It will be so very irritating because of the rich plexus of nerves which supplies the cornea and the conjunctiva. Both are richly supplied, and the nasociliary division of the ophthalmic division of the trigeminal nerve is the nerve which supplies the cornea. Remember this, because this point I will again reinforce when I speak to you about viral keratitis. Okay. The next layer, or rather the big middle layer of the cornea, is the stroma. Stroma is made of collagen, and this collagen is arranged in a perfect lattice pattern. Lattice pattern. That is the pattern in which the stroma is arranged in this corneal stroma. The collagen is arranged in the corneal stroma. This is very important for allowing vision, allowing transparency. We will discuss what is transparency of the cornea and what are the attributes of the cornea which keeps it transparent. That when we discuss, we'll discuss this again. But here you remember, corneal stroma has collagen in a perfect lattice pattern. Decimex membrane is the next membrane. This Decimex membrane is the toughest layer of the cornea. If we will presume that the cornea is infected with the corneal ulcer and it is totally eroding the cornea, and it is about to perforate, the pre-perforation stage, even then Decimex will offer the maximum resistance. Decimex is the toughest layer of the cornea. It bulges, and once it bulges, it will form a decimetocele. Once that also breaches, only then you will have a corneal perforation. So if at all somebody asks you which is the toughest layer of the cornea, then you will have to say Decimex membrane. And one another important point in Decimex membrane is the edge of the Decimex membrane. The edge of the Decimex membrane is called the Schwalbe's line. You would have remembered Schwalbe's line being discussed in angle structures. When we discussed angle, we discussed Schwalbe's line. So Schwalbe's line is a very important line which is formed by the edge of the Decimex membrane, and it forms one of the first structure of the angle. Next is the endothelium. The endothelium is the most touchy layer of the cornea. It is very, very touchy. It is very sensitive. It will never regenerate. Unlike the epithelium which regenerates, endothelium never regenerates. Then what will happen if there is some endothelial cell loss? Then that area is covered up by adjoining endothelium. Adjoining endothelium covers that deficit, small defects in the endothelium. And this is how the endothelium keeps covering the inner surface of the cornea. And this endothelium also is very important in keeping the cornea dry. We will understand it in the next slide. Keeping the cornea dry is one of the important reasons for cornea being transparent. So this is an overview of the 5 layers of the cornea. Dimensions of the cornea. Cornea is a prolate surface. It is a prolate surface. It's a prolate surface. And the cornea has a diameter of roughly 11 to 12 millimeters horizontally and 10 to 11 millimeters vertically. This is the diameter of the cornea. If you want to measure the diameter of the cornea, you need a separate instrument. We'll discuss this. Instrumentation on the cornea is a very interesting area. We'll discuss this separately. Similarly, the radius of curvature. The radius of curvature of the cornea, the anterior surface of the cornea, is roughly 7.8, which is called the K reading. We will again in detail discuss about this. But here you remember that 7.8 is the radius of curvature of the cornea, and 6.5 is the radius of curvature of the posterior surface of the cornea. Okay, anterior surface is different, posterior surface is different. There can be unique diseases affecting both these surfaces, like keratoconus. There can be keratoconus of the eye, which means regularly the anterior surface of the eye, or there can even be a posterior keratoconus. Posterior surface of the eye can be keratoconus, suffering from keratoconus. So remember that. Next is corneal thickness. The corneal thickness is in the center of the cornea somewhere around 550 microns. We refer it to as microns, 1 in 1000th of a millimeter. The peripheral cornea is a bit thicker and it is roughly 1 to 1.2 millimeters. This is peripheral cornea. So we have a peripheral cornea and we have a central cornea. Central cornea is 550 microns, peripheral cornea is 1.2 millimeters. Corneal transparency. We just discussed that cornea is unique in being transparent. What are the things which keep the cornea transparent? Immediately what will come to your mind is the avascularity, isn't it? Avascularity. Because in conjunctivitis, we discussed a type of conjunctivitis called trachomatous conjunctivitis, which is caused by chlamydia trachomatis, and we said it is a blinding disorder. Question will be like, how will it cause blindness? How will a small keratoconjunctivitis cause blindness? The answer is the pannus formation, scarring and pannus formation leads to blindness. So here you understand the importance of cornea being avascular. Similarly, there is uniform spacing of the collagen fibrils. This is the next important thing. There is uniform spacing of collagen fibers, and this is in the lattice pattern. We discussed no lattice pattern. If this pattern is disrupted, then you get a scar. A corneal scar is nothing, again collagen only. Cornea normally it's collagen, even the scar is collagen, but the normal cornea is clearly spaced in a lattice pattern. The scar is irregularly placed collagen, and that is why it is not transparent. The refractive index of the cornea is uniform. The refractive index of the total cornea, though cornea has 5 layers, the refractive index of the cornea is uniform, and that creates the transparency. The lattice arrangement we just discussed, lattice theory. Then there is a sodium-potassium ATPase pump. Sodium-potassium ATPase pump. There is a urgent need for dehydrating the cornea, because I told you cornea takes a lot of nutrition from the aqueous humor. Aqueous humor percolates into the cornea but shouldn't stay inside the cornea. Once the nutrition is given, it should go out, and that work is done by the sodium-potassium ATPase pump, which is called the endothelial pump. And this is the necessity for endothelial cover to the cornea. Similarly, the corneal nerves. Cornea has nerves, as we said, the nasociliary nerve, but the nerve fibers are demyelinated. Being demyelinated is a big advantage. That is why it is transparent. It is transparent. So these are the reasons for corneal transparency. Corneal functions, mainly transparency is its function. What else is its function? It's mainly transparency. And the refractive index, which we discussed, no, refractive index of 1.37 and a refractive power of roughly 40 diopters. If you remember this as 40 diopters, will be better. 40 diopters of refractive index and refractive power. It maintains the structural integrity, because if the cornea perforates because of a corneal ulcer or a corneal damage, cornea perforates, the eye cannot survive. Eye cannot survive. And that is why if a cornea becomes sick, then we remove that cornea and transplant it with a healthy cornea from a donor. And that is done for keeping the structural integrity intact. And it protects the eye from lot of abnormal or unwanted substances. It is on the surface of the eye, and the only protection it has is the tear film and the lids and the tear film. So lids and tear film are the main structures which protect the cornea. Even some foreign body comes towards your eye, then the lid reflects and the tear film should be some protective agents of the foreign body. If the foreign body beats these two structures, then it will come and injure the cornea. So that is the story of corneal foreign bodies. Okay. So how will you evaluate the cornea? If you want to evaluate the cornea, you'll have to take a history. You'll have to take a history, like you have to ask him, ask the patient, what are you working as? Are you exposed to chemicals? Are you exposed to ionic radiation? Are you exposed to radioactive material? Are you exposed to lot of UV light in the course of your work? And then once you've taken the history, then you do an examination. The examination can be just with a torch and loop examination, a torchlight examination, or it can be with a slit lamp examination. Slit lamp examination is pakka, clear, perfect examination. A torch oblique illumination with torchlight examination is a examination which needs to be followed up with a slit lamp examination for confirmation. Then you have some bedside tests, like you can test the corneal sensation. You can test corneal sensation. You can test how much tear film is there in the cornea with the Schirmer's test. You can do a Roplas and see if there is a dacryocystitis. These are all bedside tests which you can do for the cornea. Next is laboratory. In laboratory, you can do lot of corneal diagnostics. We will discuss that separately. Then finally, there are a lot of procedures which we do on cornea today. Like we can do a keratoplasty. I told you, no, we can remove the cornea, sick cornea, and keep a donor cornea in that place, and that is called corneal transplantation. Similarly, we can do laser procedures, LASIK, excimer, SMILE. These are many laser procedures which are done on the cornea, and these can be done for patients. For that, we need to do some imaging. Imaging is an important study of the cornea, like studying the cornea like a geography map, like doing a atlas map of the cornea. That is called corneal topography. This corneal topography is a very important investigation today, which gives you a lot of detail about the cornea. More than that, in cornea, bilaterality of the diseases is an important thing. Most of the corneal diseases, except say injury, most of the corneal diseases are bilateral. So when they become bilateral, that becomes very dangerous, because one cornea being affected and the other cornea being normal at least will give the patient one-eyed vision. The patient at least will have one-eyed vision. But if there is a bilateral disease, certain times with an age of onset which is from a very young age, and the mode of onset is certain times insidious, or there is a trauma or a chemical injury which precipitates everything, there is a surgery history, and post surgery there is a development of these diseases. All these are very important history parameters which you have to specifically ask in patients whom cornea has a opacity. Cornea has opacity, cornea has a disease, cornea has a vascularity into the layers of the cornea called pannus. All these things, the corneal scarring process, corneal curvature being abnormal, cornea becoming opaque, all these need to be understood. Then you'll have to take a pakka history before doing an examination, and we will go on to study about examination. Thanks. Now you just focus your mind on whatever we have discussed, the layers of the cornea, the individual structures in the cornea which are important, and then try to analyze the further classes. And when you go through the further classes, you will be taught about each of this in detail. Thank you for now.